Good evening, my name is Dr. David Doman, and welcome to another edition of Housecall. Tonight's topic is urinary tract issues. What new therapies are available? Find out right now. My guest this evening is Dr. Bart Radolinski, a noted urologist here in Montgomery County. Dr. Radolinski, welcome to Housecall.
Thank you. Thank you for having me.
Tell our viewers briefly about your professional background.
Well, all of my training was actually at Georgetown, starting with undergrad through medical school and then eventually through residency. So I've been kind of a local guy since college and started practice in 2008 here in Bethesda in Montgomery County. Been here ever since.
And which group do you belong with?
With Urological Consultants, and now we're under the umbrella of Chesapeake Urology.
Very nice. So there's so many topics we're going to be covering this evening dealing with the urinary tract. But let's start out with a very important one to many of our viewers, and that's prostate cancer. How common exactly is prostate cancer in the USA?
Well, the best way to probably put it is that about 1 in 6 or 1 in 7 men will be diagnosed in their lifetime. So being a man, having a prostate puts you at risk.
Okay. And given how common it is, let's discuss some of the screening strategies available. And it's my understanding there's been some controversy about what is the appropriate strategy.
That's right. In 2012, the United States Preventative Services Task Force came out with a D grade recommendation against prostate cancer screening.
What does D grade mean?
D means don't do it, basically.
Okay.
Using the letter grades that you might be used to in school, A, B, C, and D.
Right.
A has the top level best evidence to go ahead and screen because there's far more benefits than risks, versus D, which is basically there's no benefit to this. Caused a lot of controversy in both the urological and the oncological communities.
Oncologic meaning cancer.
That's right. Because of the concerns that the committee may not have interpreted the studies the same way that the community at large would have. The most recent recommendations are apt to change. They are going back to a C grade recommendation if the draft that they currently have proposed goes through. As you know, they look at these information studies that are published in the datas and try and keep up to date. Mm-hmm. So based on sort of the latest and greatest, they're working to walk back a little bit of the recommendations where they said absolutely no one should benefit from screening. So to fall more in line with the American Urologic Association, the NCCN, the American Cancer Society, men between the ages of 55 and 69, they'll recommend at least having a conversation with your physician as to whether screening is appropriate. Mm-hmm. So not fully screen everyone, but at least opening up the conversation to see if there's a benefit, if it's appropriate for the individual.
So what are some of the screening options available if a patient opts to go in that direction?
Well, I think the biggest advancement that we've seen in urology over, I'd say, the last 5 years, and interestingly, I would say that the task force's recommendations were a bit of a wake-up call, is the recommendation not to treat when it's appropriate. In the past, we had very few reliable studies to tell us that we could watch certain types of prostate cancer. So more often than not, a diagnosis would lead to treatment, be it surgery or radiation, the two most common forms of treatment, and their attendant side effects and complications. Over the last 5 years, and really starting 10 years ago when these studies really got underway, we've realized that what we call lower grade or low risk prostate cancer can be safely watched. And in about half of men, low grade disease will not progress and not lead to life-threatening consequences. So identifying those men and then choosing not to treat is probably the most interesting and exciting finding and development that we've had in urology over the last 5 years.
So if a patient wants to be screened, what are the screening options available?
So the basic screening options is an exam of the prostate done in the doctor's office.
A finger exam.
A finger exam,
okay.
And a blood test, a PSA test.
And that stands for?
Prostate-specific antigen.
Okay.
It's a blood test that's designed to try and predict not a diagnosis of prostate cancer, but who's at high enough risk where a biopsy would make sense.
All right.
So the PSA or the prostate exam on its own can't make the diagnosis, but they do tell us who might be at high enough risk where the next step, a 15-minute biopsy procedure, usually done under a local anesthetic, makes sense.
And are there any x-rays that you order to evaluate for prostate cancer?
So this is an interesting field where using MRI technology and using sort of maybe more elaborate blood testing, we're starting to try and find, well, who's really at risk versus who can safely continue screening with further blood testing. PHI tests, things like 4K score, these are blood tests that patients can have, combined with MRI imaging, are really starting to pinpoint who's at high risk versus who can be carefully watched, maybe even above and beyond what the PSA could do for us before. The PSA is still the bedrock, but we're starting to develop more testing to get better at screening smarter.
So if you find that these predictive variables, these other blood tests or the MRI indicate a higher risk of aggressive disease, then those are the patients where you're going to sit down and be more inclined to recommend some sort of treatment.
Well, at least as a first step, a biopsy.
Yeah.
And then if the biopsy confirms more aggressive disease, treatment would be the next step.
All right. So because it's such a spectrum, as you know, you may have somebody who's got very slow-growing prostate cancer where the odds are very high they're going to probably die from an unrelated issue. And yet the other extreme, as you well know, is the aggressive prostate cancer, where they may develop spread off into bone or other organs. So it must be a real challenge to sort this out.
Well, this is another, call it a hot topic in urology, where genetic testing of a diagnosis of the tissue that's been diagnosed with prostate cancer can help give us insight. Right now, we don't have a reliable indicator to say that, well, this is the prostate cancer that will never progress. If we did, then patient wouldn't really need follow-up. You could reliably tell them they'll be fine and nothing further is needed. Mm-hmm. We don't have that yet.
Yeah.
So when we talk about watching patients, it's really active surveillance, and the operative term there is active, that there is a process, there are regular biopsies, usually no more than once a year, and follow-up lab testing and imaging. Using these genetic tests, we're trying to find that dividing point between, are there prostate cancers that are predictably not progressive and going to be what we call indolent, meaning yes, mild and not particularly aggressive, in which case we can tailor that surveillance to a more, or I should say a less aggressive pathway, versus prostate cancers that look under the microscope to the pathologist to be not particularly aggressive, but genetically may have a hidden more aggressive component. And those patients would probably benefit from active treatment.
If you make the diagnosis of prostate cancer in somebody who's on the younger side, let's say 50, mm-hmm, are you more likely to treat because of the longer timeline as opposed to somebody who's 70?
That certainly factors into it. And most of our studies suggest that the longer timeline you have, the more benefit you get from treatment. Which sort of makes sense. Just as you alluded to earlier, if something else might get you before prostate cancer does, well, it doesn't necessarily make sense to be overly aggressive about the prostate cancer. You treat the patient, not the disease, as we were all told in medical school.
Sure.
So certainly diagnosis at a young age factors into it because there's a lot of living left to do, and we want to protect that and keep it as healthy as possible.
You mentioned a moment ago genetic testing to provide some sort of a crystal ball to manage a patient. Is there a familial risk for prostate cancer?
There is. Having a primary blood relative, father, brother, or in some cases a son, with prostate cancer puts you in a higher risk category for developing the diagnosis yourself. Interestingly enough, last year a study came out that showed that patients that have prostate cancer running in their family have better outcomes than patients that are sort of detected off the street, if you will. Now, we don't know if that's because hereditary prostate cancer is less aggressive, or if it's because you know your dad had prostate cancer, you're more likely to go see your doctor and get checked for prostate cancer. So that's not clear, but it was an interesting finding that just because you have a family history doesn't mean the prostate cancer is more aggressive or more dangerous.
Did they look into those that were treated versus not treated in that study?
It was just sort of correlation over time. Yeah. So very basic, very broad sort of look at the disease process.
If you then determine somebody has prostate cancer and you and the patient agree that therapy instead of just monitoring is the way to go, what are some of the treatment options you can potentially offer a patient?
So as a urologist, my specialty in our practice is prostate cancer surgery with the robotic or the Da Vinci approach. This is basically laparoscopy, the keyhole surgery that has been around for decades at this point, using small incisions, cameras, and instruments controlled by the surgeon but outside the body to effect a change inside, meaning avoiding a big incision to actually put our hands to do the work inside the patient. The robotic technology is really just an extra layer of assistance during that laparoscopic surgery, allowing for wristed instruments, so similar to our hands, they move on wrists, and better vision and cameras so that we can see better. Not surprisingly, when you have better dexterity and you can see better, you can do a surgery more easily, more smoothly, with better outcomes for the patient.
So what are some of the concerns, the side effects or complications of prostate cancer surgery?
So whether you're having surgery or radiation to treat your prostate cancer, there's always a chance of having difficulties with urinary function or sexual erectile function. Okay. In the past, with open surgery, the urinary and erectile function, I think, was much more common, or excuse me, erectile dysfunction was much more common. Now with the robotic and laparoscopic surgery, the rates of complications or the rates of having those side effects are on par with radiation. So oftentimes patients were forced to choose in the past between having the prostate cancer removed surgically but exposing themselves to these side effects at a much higher risk than radiation, which of course treats the cancer where it lies. But now with a kinder, gentler approach with the robotic platform, there's less risk involved. As you know, it'll never be zero risk with any treatment, but it seems to be a reduction in risk compared to the open techniques that we had used in the past.
Have you found if there is sexual dysfunction after the procedure that using some of these ED drugs may be helpful?
As I tell my patients when I counsel them about potential side effects from the surgery, we have lots of tools in our toolkit to manage erectile issues, be they oral medications like Cialis, Viagra, the commercials that are so common on TV, and even what we call second-line therapies, which actually have been around for a lot longer than the oral medications. Injection therapies, urethral suppositories, even things like vacuum pump devices, and all the way up into and including penile prosthesis. Right. So the comment I always make is where there's a will, there's a way. Right. There's usually a technique or an intervention that we can do to help with sexual function, be it after prostate cancer surgery or just a patient who has significant erectile issues.
What are your thoughts about radiation therapy?
Radiation therapy is an excellent option for treating prostate cancer. Any patient who's diagnosed with prostate cancer should have a conversation with their urologist, who is a surgeon, and a radiation oncologist, so that you really hear both sides of the coin, both options, because these are really the mainstays of treatment. Some will prefer surgery, others will prefer radiation. It's not so cut and dry as to what's the best approach. It often comes down to patient preference. The radiation options are pretty varied. There's the sort of classic, what we think of external beam radiation, where a patient is lying on a gantry and invisible painless beams of radiation are applied to the prostate. Mm-hmm. They've even tried to, and successfully so shorten the course of therapies, usually instead of an 8-week course with things like CyberKnife or what we call fractionated radiation, they can reduce that to about a week's therapy. Wow. We're not sure whether that'll have the same good long-term results over the years to come, but certainly the findings are promising.
Well, that's an excellent summary to prostate cancer. We're going to pause briefly for a public service announcement. More with Dr. Bart Radolinski in a moment when we review urologic issues. We'll be right back. We're back. My guest this evening is Dr. Bart Radolinski, and we're discussing urinary tract issues. Dr. Radolinski, when we paused for the break, we were discussing prostate cancer. Let's shift the topic now to benign prostatic disease, BPH. Tell our viewers, how common is this an issue for men?
Very common. Having a prostate and being a man obviously go hand in hand, and many men as we age will develop enlargement of the prostate, and that affects the quality of our urinary function. And it's really an interplay between the prostate and the bladder. So we generally describe these as lower urinary tract symptoms, but often the driving factor is enlargement of the prostate, or what we call BPH.
And how does BPH therefore present in men?
Most commonly it starts with slowing of the urinary stream, or a sensation of dribbling after urination, and maybe a sense of not emptying completely. But these can be subtle, and oftentimes just waiting a little longer in the bathroom will sort that issue out. Over time, these symptoms can progress to urgency, frequency of urination, and even incontinence episodes.
And how do you distinguish between benign prostatic disease versus the more serious prostate cancer?
Well, fortunately, the time at which prostate cancer would cause these kind of symptoms would only be in its late stages. So it's rare for a man who has the beginnings of urinary symptoms to have them as a result of prostate cancer. So by far the most common cause is just benign enlargement of the of the prostate.
Right.
But checking a PSA, doing an exam of the prostate, that'll help your urologist differentiate between the two.
So once you've determined somebody has the benign prostatic issue, what are some of the treatment options a patient has?
Well, in the past, our only options were medication therapy and surgery, and a pretty wide gulf in between. I should say there was always the possibility of simply watchful waiting, seeing if the symptoms improve, or just toughing it out, so to speak.
Sure.
But once a patient was past that and wants treatment, then daily medication to help relax the prostate tissue and allow for better outflow from the bladder, or to shrink the prostate, were primary options. When that failed, surgery to resect or excavate the enlarged tissue, usually through the urethra in the outpatient setting under general anesthesia, was the fallback position. Unfortunately, that left a lot of patients sort of hanging in the middle. If you can imagine, if you're a patient who has been treading water on medication, but not doing as well as he would like, but the only other option would be surgery, that might be a bridge too far for the patient to cover. So a lot of patients struggled and continued on medications, saying that, well, I'll just keep this going because I don't really want any surgery on my prostate. So over the last 5 to 10 years, there's been a lot of progress made on what we call minimally invasive therapies for BPH. These are non-surgical options where there's not formal cutting of the tissue, but in a 15-minute procedure, 30 minutes at the outside, either under local or twilight sedation, we can effect change to the prostate so that we can mechanically improve the emptying of the bladder by opening the channel, either with urethral suture suspension or thermotherapy, injection of heated steam into the prostate. Not nearly as aggressive or as risky as surgery, but certainly more effective than medication. So men no longer have to choose either struggle and tread water on a daily pill or opt for aggressive surgery. There is an option in between that I think can serve a lot of need.
Let's go over each of those options you mentioned. There was a thermal approach. So explain to our viewers what that encompasses.
Yeah, formally it's called microwave thermotherapy, and it goes by a lot of brand names, but the general idea is the same, that you apply a heated catheter to the prostate tissue, and that over time that will cause prostate tissue to retract, to shrink basically. If you think of the prostate as surrounding the base of the bladder and blocking outflow from the bladder, sort of like a narrowing of a pipe, by heating that tissue, you can make the pipe wider and allow for better emptying.
And how durable is that effect?
Usually we tell patients it can last between 3 and 5 years, but it's repeatable. So if there is a recurrence of symptoms and we confirm that the prostate indeed has grown and sort of obstructed things again, you can repeat the procedure.
And what about the other two options you mentioned?
The option that I think probably has the best data behind it, the most durability, and the most promising is what we call urolift, or prostatic urethral lift. This is basically a suture suspension of the tissue. We get about a 15-minute procedure where, as a urologist, I would go in and I describe it to my patients as sort of pulling curtains out of the way of a window. If the prostate is sort of blocking the urinary channel, putting in a few sutures that attach to the outside of the capsule of the prostate can pull the tissue apart and open the channel to allow for easier emptying. Over time, not only does that help the bladder empty better, but it allows the bladder to work less hard to do that emptying. So symptoms improve, and so far we have 5 to 6 year data on durability, meaning we've seen it last that long, and that study is still ongoing, so we'll see how long it lasts before patients need repeat therapies. But it's a very interesting line of treatment that we found.
And the third option?
The third option is basically heated therapies of some kind, usually steam, hot water, applied into the prostate directly by injection. Has the same effect as the thermotherapy, except a different delivery mechanism. Again, same idea, shrinking the enlarged prostate tissue, opening the channel, giving things more room to empty.
And is that as durable as the other options?
The studies seem to suggest yes.
Okay.
All of these fall slightly short of surgery, but certainly the trade-off is less risk, less hospitalization time, less invasive.
Sure.
That's right.
Let's shift gears then to some of the urinary tract issues for women. What are some of the common issues you run into?
Well, as you know and as our viewers know, that both men and women have bladders. Women don't have prostates, but changes in the functioning of the bladder can often lead to difficulties with women's urinary function. We've generally called these overactive bladder symptoms, and these are the most common: urgency, frequency of urination, and what we call urge incontinence, the sensation that when the urge to urinate comes, it can't be put off and even results in leakage. There are also incontinence issues, what we call stress incontinence, coughing, sneezing, standing up from a chair, laughing, causing leakage.
Yeah.
This is slightly less to do with the bladder itself and more to do with the sphincter. But it's the overactive bladder, the urge symptoms, where in the past they've been the toughest to treat, and we found a lot of progress in options to treat those. For example, when you have patients who, well, first-line therapy being medication, aren't successful, in the past all we had to do was, or all we had to offer was simply reassurance that, well, this is the best we can do. Over, again, the past 5 to 10 years, what we found is that we can address the bladder in non-pharmacologic means to try and improve urinary symptoms. Things like InterStim, things like percutaneous nerve stimulation, even using Botox can be effective in helping reduce urgency and frequency of symptoms when medications aren't successful.
And just to be clear for our viewers, this is the very same Botox that a plastic surgeon would inject in the face to get rid of wrinkles.
That's right.
And how does it work from your standpoint?
Well, the mechanism is the same. The Botox, the botulinum toxin, basically interrupts muscular function. So the prevailing theory of the overactivity of the bladder is the muscle of the bladder is irritable. So injecting in select locations in the bladder, and this can be done under a local or a twilight sedation, can help the bladder muscle be less irritable, be less aggressive. And that in turn leads to less urgency, less frequency, and less incontinence, fewer incontinence episodes. So it's the same as a plastic surgeon might do to the face. It's using the same mechanism but on a different muscle to effect an improvement in urinary symptoms.
It's interesting how many uses have evolved with Botox. For example, in my field, gastroenterology, we will inject it if somebody has achalasia, spasm of the lower end of the esophagus, and patients can't swallow. So we utilize that in a similar fashion.
That's right.
I know an emerging therapeutic option in the field of urology is different types of nerve stimulation. Explain to our viewers the different types of nerve stimulation available, and when do you utilize that technique?
So the nerve stimulation usually breaks down into two options: peripheral or more central. Technically, it's all peripheral. As you remember, the central nervous system, we try not to poke around too much in. But in urology, there's the sacral nerve, and then there are peripheral nerves that are extension from this. The way that this works is not entirely clear, but we know that if you stimulate the same nerves that control the sensation and the function of the bladder, you can sort of hit the reset button on the irritability of the bladder muscle. Bladder muscles, or any muscles, are controlled by nerves. Right. So you can either target the muscle for improvement, or you can target slightly upstream the nerve. Sacral neuromodulation is basically trying to do this at the nerve root right outside the spinal column. This is something where a patient would come in for a test procedure, and if effective, then have a battery implant of a stimulator that they can themselves adjust, turn up, turn down to produce the results that they would like in terms of reducing urinary symptoms. An alternative to that is peripheral nerve stimulation. The sacral nerves, if you follow them down, go down around the ankle. And by stimulating nerves in the office setting with a tiny electrode, usually done on a weekly basis over the course of about 12 weeks, you can slowly retrain the nerve and therefore the bladder muscle to be less irritable, and it relieves symptoms that way.
And what is the data on this? How long have they been using this sort of technique?
The sacral nerve stimulation, I believe, comes initially from deep brain stimulation. These are the same sort of nerve ideas, nerve root stimulation, just applied to a different setting. So that's been around for, I think, well over a decade now. Actually, peripheral nerve similarly. The sacral nerve data is probably stronger, but it's a little bit more invasive because it involves a procedure and eventually an implant of a battery pack and a generator.
Sure.
The peripheral nerve stimulation doesn't involve any procedures, any anesthetics, but it needs to be relatively continuous and then with maintenance therapy to have those results. Meaning you can't just flip a switch and fix the nerve. You have to continually stimulate that nerve to have an effect because of how it affects the muscle.
Is this nerve stimulation techniques something that is covered by Medicare and most insurance companies?
In most cases, yes. Insurance companies realize that if patients can come off of a daily medication, it will wind up being a cost savings in the long run and also improve the quality of life of the patient.
Very interesting. We have 1 minute left. Are there any new developments for ED that are on the horizon?
Yes. The latest development that we had in erectile dysfunction were the oral medications. These have been now around for almost 2 decades at this point, and some of them are even coming off patent finally, so costs might come down on those. But aside from that, we haven't had many changes or breakthroughs. What's interesting lately is that we're looking at sound wave or shock wave therapy of the penile arteries to promote growth and actually reverse the changes that lead to erectile dysfunction to begin with. So as you know, the erectile medications work by dilating blood vessels. Blood flow is what erections are built off of. So with good blood flow, usually come good erections. As we age, our blood vessels are not as robust and not as good with providing flow to tissue, and the penile tissue is often the first to succumb to that. So the oral medications, their role is to help dilate those blood vessels, and that's how they improve erectile function. With the shockwave therapy to help open those blood vessels in a more durable fashion, this is a non-pharmacologic, meaning without medication way of improving blood flow and potentially stimulating regrowth of new blood vessels so that the quality of the erections can improve without using pills or medicines to achieve that.
Excellent. I'll have to stop you there, unfortunately. We're out of time. Thanks to my guest, Dr. Bart Radolinski. Thanks to my terrific team here at the station. And thank you to the viewer for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a fascinating one. Dr. Monique Newell of the Center for Disease Control and the Maryland State Department of Health will be giving us an overview of the Zika virus. See you then next time for another edition of Housecall. Good evening.